Oh my God, I literally said I was not going to stop recording, and then I got a call, and I had to, bruh. So, what was I saying? Okay, so these cells, they are antigen presenting cells, okay? Which we are going to call APCs, which stand for antigen presenting cells. And the thing is, they're not the only cells that can do this, okay? B cells, these guys, they can also act as antigen presenting cells. This is all going to make sense later as I go deeper, so just like flow with me here, all right? So these are called antigen presenting cells. Next, let's talk about okay, so now I've explained to you all the adaptive immunities, and I've explained to you what they do. So I already talked about white blood cells, so I'm gonna move on to the complement system. So the complement system is here. It's a part of something called plasma protein synthesis. Again, just keep the name, just know the name. You don't really have to think too much into it because I will go in depth, but just know the name. So a complement system is activated by a lot of pathways. There's 3 main pathways that will activate your complement system. But for the sake of, actually no, Professor Hahnemann said we don't need to know those three things that will activate this. So I'm not gonna talk about them. But one thing you should know is that once activated, they will cause these things. So they'll cause opsonization, anaphylatoxins, and cell lysis. Okay, so opsonization is basically when the complements, they mark a bacteria. So say this is a bacteria. So the complements are basically going to go to the bacteria and be like, hey. And the bacteria is going to be like, hello. And the complement's going to be like, okay. And then the complement is going to tell a cell, another cell, which is, it's probably going to be a white blood cell. He's going to go tell that white blood cell, like, hey, go kill that guy. And the white blood cell's going to be like, okay. And he's going to go there. And then this guy will attach himself to this bacteria, right? And the white blood cell is going to see that he's attached himself and then use that to know, okay, so that's the guy I'm supposed to kill. And he's going to kill him by phagocytosis. So he's going to eat him. And that's pretty much how that works, okay? Then we have an anaphylatoxins, and it kind of sounds like anaphylaxis, and that was not an accident. Okay, whoever named it because of this, all right? And why is this? That is because the complement system will trigger mast cell degranulation. And when your mast cell degranulates, okay, this is all gonna make sense later, just follow along. When your mast cell degranulates, it releases histamine. Histamine will then lead to vasodilation and bronchoconstriction. And bronchoconstriction is what causes anaphylaxis. Actually, no, bronchoconstriction is anaphylaxis. Okay, so if you have this thing going around unchecked, it will lead to anaphylactic shock because of this pathway. Okay, so they're going to trigger your mast cell, which is going to trigger histamine, which is going to trigger vasodilation and bronchoconstriction. So that is why it's called anaphylatoxins, okay? So then we have cell lysis. And this is actually, which is basically just creating holes in a cell wall, okay? This is supposed to be for killing the bacteria, right? So it's going to create holes in the bacteria's cell wall and ultimately killing it. But sometimes it can end up affecting our normal cells, and that can lead to tissue injury. Because even though it's supposed to only to lyse the cell, lysing basically means cutting, okay? Even though it's supposed to lyse the cell wall of a bacteria, sometimes it can lyse our own cells, and that will lead to tissue injury because, cells make up tissues and whatnot. Then we have chemotactic factors. And I'll explain what that is in a few minutes, but yeah. And next we're gonna talk about the clotting system. And I want to say, something that helps me remember is that your innate immunity, everything that does not have to do with T and B lymphocytes are innate immunity, okay? If it's not about T lymphocytes and it's not about B lymphocytes, then it is innate immunity. Okay, these are the only 2 things you need to worry about when you're talking about adaptive immunity because they are the big guns. Right, they are our 2 most important people. So if it's any of these things, if it's anything else, if it's something that you see on the exam that I did not mention, it as adaptive immunity, it is innate. If it is not a T lymphocyte and a B lymphocyte, it is innate. Okay, so right, where was I? Okay, so the clotting system. This is also a type of innate immunity because it's not T or B lymphocyte. So we have again, there's pathways that will lead up to this, but we don't care about that. We just care about what it does. And the thing is, it creates thrombin, which creates fibrin, which leads to blood clots. So the clotting system will lead to blood clots, and then it also leads to increased cellular permeability, and it also causes chemotactic factors. Okay. Then we have the kinin. I don't know how that's pronounced. The system. Okay, and it contains the main thing you need to know about this is something called bradykinin, and bradykinin is basically pain. Whenever you hear bradykinin, think pain. Whenever you see pain, think bradykinin, because there's other things that can and it doesn't cause pain, but it's what is responsible for us feeling pain. So when we think about the 3 cardinal signs of inflammation, which is swelling, heat, and redness. And pain and you'll see what I'm talking about later, but pain and dysfunction are like part of it, are like secondary signs of inflammation, right? So swelling, heat, and redness are the main 3. And then we have pain as a secondary character that is caused by bradykinin. This is what makes us feel pain. And it also causes increased cellular permeability. So chemotactic factors, I said I was gonna explain this later, but chemotactic factors is basically when it basically like is something moving, because tactic means moving, and chemo means chemical. So you're basically moving towards a chemical stimulus. So this causes the white blood cells, that is these guys, to move towards a chemical stimulus. And when I say white blood cells, it is all of these guys, but we're mostly talking about this guy, the macrophage. Sorry, no, the neutrophil. And we'll get to that, but just know. I feel like the thing with patho is the more you know, the more you know. You know what I mean? Like, you kind of have to know a lot for things to start making sense. Like, at the very beginning, it's just a bunch of memorization, but then the more information you know, the more you can piece things together, and it just kind of works. That's what I like about patho, even though the class itself is really hard. So now I've gone over the complement system, I've gone over the clotting system, and I've gone over the kinin system, all right? So remember, bradykinin, pain. All right, if you hear pain, think bradykinin. And then for the clotting system, you should know it causes blood clots. And then for the complement system, you should know it can lead to anaphylactic shock. I feel like this could show up on the exam because this is a very patho question to have, like, And then we have tissue injury. This one wasn't in our slides, but it was in the textbook. So it's good to know, but And they all have chemotactic factors. I didn't write it for this one because I forgot, but they all have chemotactic factors. So they will all call white blood cells to the site of, it could be an infection, it could be bleeding, whatever it is, it's going to call a white blood cell, and they will all increase cellular permeability. Okay. Next, we have inflammation, which is this guy. All right, the bane of my existence. Okay, I forgot to mention this, but the first line of defense is constant. It is always working 24/7. When you eat, when you sleep, when you bathe, when you drink water, it's always working, okay? The second line of defense is activated, all right? So once a pathogen gets in, your second line is up and running. It is going, okay? It's not gonna wait for anything. It's not gonna take time to think, oh, what do I, no, it's just gonna start shooting, okay? And then we have the adaptive, which is activated, but it's delayed. And that's because they're these guys, okay? They're the big guns. And when you're loading a big gun, it takes time, right? Like when you're gonna put all the ammo in the gun, it's gonna take you some time. So for them to be up and running, it's gonna take time. That's why it's delayed, which is why this one has to be fast so that they can buy time for these guys to get ready. Okay, so I just wanted to mention that. So let's talk about inflammation, which is practically our body's response to everything. And when I say everything, I literally mean everything, almost everything. Okay, so when you get punched in the face, you're gonna have inflammation. When you get an infection, there's gonna be inflammation. If you cut your hand, there's gonna be inflammation. If you experience some sort of blunt trauma, there's gonna be inflammation. If you choke, like lack of oxygen, there's going to be inflammation. There's always going to be inflammation, okay? It's just a lot. And why? Why does the body keep doing this as its go-to? Well, that's for three main reasons. Number one is to confine damage. Number two is to kill microorganisms. And number three is to get rid of debris. And in case of an injury, like an open injury or just an injury, it's going to rebuild damaged tissue. So that's this. Okay? And now, depending on what type of inflammation it is, it can look very different. Okay, so there's local inflammation and systemic inflammation. So local inflammation means just one part of your body, right? So say you get punched in the face, right? Your eye is going to swell. That's just your eye, right? The rest of your body's gonna be fine, but your eye's gonna swell. That's local inflammation. Systemic inflammation means your whole body, all right, has been affected by whatever is happening. And so now you're having inflammation all over. And that's going to be represented by fever. Okay, I feel like I'm jumping the gun. Let me talk about these things for local inflammation. So when we talk about local inflammation, the first thing you're going to see is swelling. Okay? Then we're going to see inflammation. I don't know why I put that there. I meant to say, this is supposed to be, well, I mean, you're going to have inflammation. That's like a no-brainer. But this is supposed to be redness. And this is heat. Right, so these are our three cardinal signs that I was talking about: swelling, redness, and heat. So if you ever hit yourself or if you stub your toe, after a while you're going to see swelling, redness, and heat. If you see these three things, that's how you know that inflammation is occurring. And then the other things we have are pain and dysfunction. And the reasons they're not a sign, they're not cardinal signs, they're more like secondary signs, is because you can have inflammation without pain. And you can have inflammation that does not lead to dysfunction. Dysfunction is basically when something stops working as a result of inflammation. So again, with the eye example, if someone punches you in the face and your face starts swelling and you can't see out of that eye, I like to describe that as dysfunction. I don't know why I'm rewriting it, but yeah. Am I recording? Okay, I am. Okay, and then for systemic inflammation, that's the one that affects the whole body. So we're looking at fever, we're looking at leukocytosis, and I love having small definition boxes for words that I don't know. And so leukocytosis is basically high white blood cell count in the blood. And that makes sense, but you'll see why it makes sense soon. Then we're gonna have plasma protein synthesis, and that is this thing that we just went over, okay? And it's gonna show up a few more times, so just know about that. And then we have plasma protein synthesis. So let me give you, I'm a visual learner, all right? So let me give you a good example of how the second line of defense works. So this is a pathogen, right? I really wish I could move this somewhere. Oh, I can. Okay, I'm gonna put that there. So this is a pathogen, right? And it got through your first line of defense, which is your skin, your mucous membranes, all that. It got through your first line of defense. And also, this is a cell, all right? So here's what's gonna happen. Your pathogens, right, the bacteria that infected your body, this could be the flu, it could be a virus. I'm gonna pretend it's a bacteria, but it literally could be anything. It's going to start attacking the cell. It's gonna be like pow, 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 pow. It's gonna start beating it up. There's different ways pathogens can affect your body. Sometimes they could cause the cell wall to break down. Sometimes they could steal nutrients so the cell's not getting anything. Sometimes they could inject themselves into the cell and reproduce. That's viral. That's what viruses do. And there's just a lot of things that cells could do. So this is just me giving an example, but there's really so many ways this could go. But basically, the cells are gonna be like pow, pow, pow. They're gonna beat it up. The bacteria is gonna beat up the cell. It's gonna be like pow, pow, pow. And then what the cell is gonna do, right, is gonna be like no, and it's gonna start crying, and it's gonna release these enzymes. I don't know if it's enzymes or chemicals. It's gonna release these chemicals. Right? And this is a blood vessel. I don't know if I mentioned that. And in your blood vessel, we have blood. But what does blood contain? Red blood cells, plasma, and white blood cells. Okay? And obviously, this is not a one-to-one drawing. Like, this isn't accurate. Like, obviously, there's going to be way more red blood cells. But in our blood, we have our neutrophils, which are these guys. And we have macrophages, which are these guys. So what happens when the cell releases these chemicals? The closest neutrophil is going to sense the chemical and be like, whoa, that's not supposed to be there. So they're going to come out of the vessel. Right? They're going to come out of the vessel. They're going to assess the pathogen. They don't grow bigger. They're usually normally sized. They're going to assess the pathogen, and they're going to start fighting. Like, hey, leave her alone. Scram, you know what I mean? But the thing is, there's 3 of them and 1 of him. So what's he going to do? He's going to send out other chemicals. He's going to send out his own chemicals, and his chemicals are going to bring other neutrophils. Okay, I feel like I'm jumping the gun a little. But his chemicals are going to cause something. And what is this thing? It's a bunch of things. It's going to cause it's going to release inflammatory chemicals. And what does that do? Well, the main thing it does is that it causes vascular permeability. Okay, so it's going to cause holes in the cell wall. And once it does this, it's going to send out chemicals that are going to recruit other white blood cells. And these white blood cells are going to go through the cell wall and come outside. Okay, they're going to go through the cell wall and come outside. And the thing is, I put only neutrophils and macrophages because they're the ones we need to focus on. But in a real scenario, there's a bunch of other white blood cells that will also be coming to the site because of these chemicals. And the movement of these white blood cells through the cell membrane, the membrane of the vessel, is known as diapedesis. just remember that, PED is like to pedal, and I like to imagine them pedaling through the side, the vessel membrane, but you don't have to use that to remember it if you don't want to. That's just me. So that's that. And then once the neutrophils come outside, they're also going to release their own chemicals. So everyone's going to be releasing chemicals. And that's going to cause an even bigger inflammatory reaction. And the reason for this is because this is a neutrophil. If you are paying attention, like if you're moving along, you'll realize that the first one was able to move through the cell wall without it being lysed. So it making the vessel wall, the walls of the blood vessel, it was able to move through it without the vessels having these holes. So then if the holes aren't for the neutrophils, then who are they for? And they're for this guy, the macrophage, because he's actually much bigger. Okay, he's much bigger. He can't just slide through the vessel walls like the neutrophils can. He has to, these holes have to be there. So he's going to slip out through the hole. And the macrophage, I made him green because I like to think of him as the Hulk from Avengers, right? So a macrophage is like Bruce. And when the macrophage slips out of the vessel wall and he interacts with these chemicals that the neutrophils are releasing, he's going to turn into... It's taking more time than I thought. Okay. He's going to turn into a monocyte. And the monocyte is like the Hulk. Okay, so if macrophages are Bruce, then the monocyte is the Hulk. Did I get that right? Oh, sorry, I mixed them up. So monocytes are Bruce, macrophages are the Hulk. My bad. Right, so once a monocyte leaves the blood, right, through the now permeable blood vessel walls by a process known as diapedesis, it turns into the Hulk. Okay, it turns into a macrophage. That's how I like to think about it. Yeah, and so the macrophage, let me see, I had a list. Okay, and so once the macrophages show up, they're also going to start fighting too. They're going to also start doing their thing, like they're all going to start fighting. But here's the thing. These inflammatory chemicals that are being released by the neutrophils is going to also bring in a lot of blood to this area. So it's going to stimulate vascular permeability. Then it's going to cause more blood flow. And well, we already know why it's making the walls of the blood vessel permeable. It's to allow all these other white blood cells to slip through, and come outside. But the reason it's bringing more blood is because, look, I've already gotten all the white blood cells. So we need more white blood cells. Like 1, 2, 3, 4, 5 are not going to be enough to deal with all these guys. Okay, imagine there's more of them. So we need more white blood cells, which means, and white blood cells come in blood. So we need more blood. That's how that works. So once these macrophages come, right, they're going to try and start fighting. Usually, well, not usually, sometimes this is enough to kill off the bacteria. So sometimes this is enough to do the job and get rid of the bad guys. Sometimes, most times, it's not. And that is going to lead to adaptive immunity. But we still have to talk more about inflammation. So just cap it there, that once the macrophages show up, right, they're going to also start fighting. They're going to start doing whatever it is they do. It could be phagocytosis. Phagocytosis is basically when a cell eats another cell. So it could eat the bacteria, it could fight the bacteria. Like there's a lot of things it can do. But once it gets there, if it realizes that this pathogen is not, easy peasy lemon squeezy, if it realizes like, oh, this is going to be a problem, it's going to kickstart adaptive immunity. And I want you to understand that this is not the only way that adaptive immunity can be kickstarted, right? Because what if you have a disease that stops your macrophages from working? Does that mean you're not going to have adaptive immunity? No, like that'd be stupid, right? So there's many types of ways that we can start adaptive immunity. But I think this is like the easiest pathway to understand when you're first getting into it. Like when I first started reading about this was the first pathway I learned, and it really made a lot of things simpler in the future. So this is kind of my roadmap if you want to look at it for a second, but you can pause it. Yeah, that's kind of what that is. Now we're going to move on to the systemic manifestations of inflammation. I think I can move you back to where you're supposed to be. Okay, the systemic manifestations of inflammation. So now we understand what inflammation is. We understand why it's happening. We understand the different types, but how does it look like to us? Or rather, how do we know that it's affected the whole body, like our whole system, instead of just a local one? And that's when we're going to go into these things, right? So that's fever, leukocytosis, and plasma protein synthesis. Those are the systemic manifestations of inflammation. We talked about the local ones already, right? So that's swelling, redness, and heat. So, okay, let me explain them in this context. So once the neutrophils release these chemicals, right, it's going to cause all these inflammatory things to happen. We're going to have vascular permeability, and we're going to have more blood flow. So take a second and walk through this with me. So if you have holes in your blood vessel walls, right, and you have a bunch of blood that's going to come rushing through the wall, what's going to happen? Some of the fluid from that blood is going to leak outside. It's going to leak outside. And the blood is not going to leak outside. You have to remember that blood is, it's not just red blood cells. Blood is a bunch of things. Okay, so we're going to have fluid leaking outside. Okay, and remember, I feel like this is also in osmolarity, that chapter in Unit 1, where once you have this hole, there's also albumin in the blood. And albumin is going to go outside too, right? Because of these holes. These are like big holes that we're making so that you have white blood cells leaving. But white blood cells aren't the only things in the blood vessel, right? So albumin is going to leave too. And if albumin leaves, then water is going to follow. Okay, so there's going to be a bunch of fluid outside. And that fluid from outside the blood vessel is going into the tissue. That's why we have swelling. That swelling is the fluid leaving our blood vessels and entering the tissue. It's entering our interstitial space. And I think it's also called our third space. That's another name for it. Yeah, that was Unit 1, interstitial space or third space. It's going to enter there and it's going to start filling up with fluid. So we're going to see a swelling. And then what of the redness? Well, blood is red, right? So if your skin is like expanding with blood, you're going to see some redness. Okay, then we have heat. Because it's swelling, inflammation, and heat. Sorry, swelling, redness, and heat. So where's the heat from? Well, I like to think about it this way. Blood carries heat. So if you have all this blood that's leaking into our interstitial space, that blood is also carrying heat, which is why if you touch a place that's sore or swollen, it's going to feel warm, right? That's because of the heat, that's because of the blood, of the fluid. So those are the signs of local. So now we're gonna move on to the signs of systemic, which is fever, leukocytosis, and plasma protein synthesis. So I'm gonna focus mainly on fever, and then I'll talk about the other two. So fever is basically, I want to say it's when we have a temperature of over 100 degrees Fahrenheit. But I guess, people are different, so it could be 101, it could be 102, depending on who you are. Sorry, I got a text message. 101, 102, depending on who you are, like what your normal is. But most times it's when you have a temperature of over 100 Fahrenheit. I feel like that's too light. I feel like I can make that thicker. Yeah, nope. Over 100 degrees Fahrenheit. Okay, and fever is caused by a pyrogen. What's a pyrogen? A pyrogen is anything that produces heat. So think pyromaniacs, which are people who like lighting stuff on fire. So that's pyrogen. Pyrogen produces heat. And then we have, there's different types of pyrogens. There's exogenous pyrogens and endogenous pyrogens. So exogenous pyrogens, most of the time they will come from pathogens, right? So things secreted by bacteria, viruses, fungi, those are going to be called exogenous because they're from the outside. And exo is outside, so, or outer. So exogenous things are going to be from outside, things that are not for us, not made by us, not for us. That's an exogenous. Endogenous is going to be things on the inside. So we're looking at our interleukins, mainly interleukin 1, interleukin 6, and then we're going to be looking at our TNF alpha cytokines. Okay. This is one thing, man. TNF alpha cytokines is just one thing. You don't have to really think too deep about it. It's a TNF alpha cytokine. Just remember it's a TNF alpha cytokine. And for interleukins, there's like almost 20 of them. There's a bunch of them. And we're not going to need to know everything and what they do, but there are some important ones. One of them being interleukin 1 and interleukin 6. So when you hear interleukin 1 or 6, think pyrogen. When you think pyrogen, you think fever, right? So interleukin 1 and interleukin 6 will cause fevers. And then we have interleukin 10, which does not cause fevers. It actually does not belong here. But it's just another example of an interleukin that you need to know, and this limits inflammation. So not all interleukins will cause fever. Some of them can do other things, like interleukin 10 limits inflammation. So this concept is not important for this specific topic, but it is important for the chapter as a whole, and we're probably going to see it again later. Okay, so now I've explained to you pyrogens and the type of pyrogens, but how do they work? Well, they work by acting directly on the hypothalamus, and it signals it to raise the body's heat to kill pathogens. And this is because, bacteria, they don't love hot places. Most of them don't love hot places. And the ones that do are not going to be infecting our body. They're going to be off in like a volcano or something. But most bacteria, most pathogens, they like our body temperature, which is about 92.7 to 99, I think. Yeah, I think this is the average. This is like for old people. I think this is the normal for old people. But this is like our average body temperature in Fahrenheit. In Celsius, it's 36 to 37. But that's just a random side note. But yeah, so the pyrogens will send a signal to the hypothalamus. The hypothalamus will then raise the body's heat, raise our temperature to kill the bacteria. But here's a downside to that. If our cells also need to be at a temperature of 92.7 to about 90, I'm gonna say 98 or 99. Right? So if our body raises our temperature to over 100, what's going to happen? Well, some of our cells are going to be affected too. Some of our cells are also going to die. That's why when someone is running a high fever, we try to cool them down, because even though it's going to kill the bacteria, it's also going to harm us in the process. So we're going to be like collateral damage. And by us, I mean our cells. Okay. So how does the hypothalamus increase the body's heat? It does it in two ways: by conserving heat and then by generating heat. So conserving heat basically means we're not going to lose any more heat. Right? We're not going to lose any more heat. Generating heat means we're going to make more. So not only are we making more heat, we're also not losing any heat. So we're raising our temperature. And how does it generate heat? Well, shivering, increased muscle contraction, and then increasing our metabolic rate, which is basically the rate at which we do things, at which we break things down. That requires a lot of energy. That's going to create a lot of heat. And then how do we stop ourselves from losing heat? Well, that's vasoconstriction. And what is vasoconstriction? That's when a blood vessel goes from this, and this is like if you cut a blood vessel in half and looked at it from the side, that's when it goes from this to this. And why would that reduce heat? Well, remember what I said about blood carrying heat? Well, if you have a vessel which is constricted, it's going to have less blood, right? And if you have less blood, you're going to have less heat because there's less heat being lost to the atmosphere. Okay, that's why when people are like hot, they start getting red because they're vasodilating. And dilating means you're going the opposite direction. You're getting bigger. So all this blood is now rushing towards the surface. That's why, especially in people who are like white or Asian, just people who are not black or dark skin in general, that's why you can kind of see when they're like flushed or hot or embarrassed, because all this blood is coming to the surface. And the blood, as it comes to the surface, that heat that it's carrying is going to be lost to the atmosphere. So we want to prevent that from happening when we're trying to raise our body's temperature. So we're going to have the opposite effect. We're going to have vasoconstriction instead. Another thing we're going to have is decreased sweating, because sweating cools down the body. Okay, but we don't want the body to cool down. We want it to be hot, so we're going to stop sweating. And that's basically that. The next thing is leukocytosis, which is increased number of white blood cell count in the blood. Now, why would we see this with systemic inflammation? With systemic inflammation. Remember this? So if you are sick, right, there's going to be more blood rushing to the area, like I said before. But because there's more blood, there's more white blood cells in the blood that's rushing to the site of the infection. So when someone is sick and they go to the hospital or to a clinic, they usually order them a blood cell count. And if you have a lot of white blood cells in your blood, that means that you're currently fighting an infection, because your body needs those white blood cells to kill off the pathogen and to release inflammatory chemicals and to do whatnot. That is why we're going to see leukocytosis. And when you see leukocytosis in the blood in general, right, that means the inflammation is everywhere. It's not just in one specific place. Okay, that means the inflammation has gone to everywhere. And then we have plasma protein synthesis. And those are all of these things. All right, those are those three pathways. And how is this a manifestation of systemic inflammation? Well, the thing is, plasma protein synthesis, right, has something called an acute phase reactant, which is still, I think, the same thing. I think they mean the same thing, but if they don't, just whenever you think of acute phase reactants, think of plasma protein synthesis. Like, just pretend that they do, because that's what I'm doing, and so far it's working for me. But like the deeper you go, the more you know. So maybe if you decide to do more research, you'll find out why. But yeah. And this is basically things that are synthesized by the liver during inflammation. And they can be pro or anti-inflammatory. So they can either be for inflammation or against it. And why is this, how does this prove that we're undergoing systemic inflammation? Well, that's simple, right? Because cytokines, those are one of the chemicals that neutrophils are going to release. Those are one of the chemical signals, cytokines, I forgot that. But yeah, cytokines, when they are released, they will go into the blood. They enter into our blood. And that blood will then go to the liver. I think that's what a liver looks like, I don't know. But once that blood enters the liver is then going to synthesize acute phase reactants. And these acute phase reactants are what are either pro or inflammatory. So when you see acute phase reactants in your body, that is a hint that, hey, that means the liver produced these. And if the liver is producing these, that means that the liver got a sign from the cytokines. And the cytokines had to have been released somewhere else. So it's really a cascade. This is really a cascade, okay? Now we're going to go into mast cells. So mast cells are things that degranulate to produce histamine. And histamine is very, very important, okay? And just remember that when a mast cell degranulates, it produces histamine. And histamine is important for two reasons. Number one, it will lead to vasodilation. And we've already talked about vasodilation, which is basically when, so not only will your blood vessel become more permeable, it's also going to dilate because of histamine. A mast cell was one of the other cells I was talking about that would be in the blood, by the way, even though I only focused on these two. Like I said, like I'm going to be introducing more and more things to kind of build on what I've already said before. But a mast cell is going to be in the blood as well. And so once it receives these chemicals, it's also going to leave and release histamine. Histamine is going to cause this vessel that is already permeable, right? It's going to cause this vessel to also dilate. That's going to make it bigger. So it's going to get bigger. We're going to have even more blood flow. Okay, even more blood flow. And once it gets bigger and we're having even more blood flow, these three things are going to happen. We're going to have hypotension, we're going to have edema, which is just swelling. And I've already explained swelling, so I'm not going to explain it again. And then we're going to have exudation. So exudation is basically leaking. Okay, it's just leaking. And let me explain that. We're going to have all this fluid leaving the blood vessel because it's now permeable, right? And because of the amount of blood that's rushing through it, imagine you had a hose, like a water hose, and you poked holes in it, and then you turned on the tap that it was connected to full volume. So all this water is going to be spewing through the hose, right? But there's also going to be water that's spewing out of the holes that you poked in the hose. So that's basically what's going to happen. And since there's all this fluid leaving the cell, the amount of blood that's going to be in here is going to be even smaller. And that is what hypotension is, because there's going to be less pressure. So that's how vasodilation can lead to hypotension. And histamine also causes smooth muscle contractions. Fun fact, mast cells are usually found in the respiratory tract and in our blood vessels. So I've already told you the blood vessel part. But now let's talk, where is it? Did I pass it? Yeah, the blood vessel part. But now let's talk about the respiratory tract part. And I said it's a fun fact, but it's actually not fun at all. Because you see, when a mast cell degranulates in the respiratory tract, it causes a smooth muscle contraction of our bronchioles. And bronchioles are the things in your lungs that help you breathe. They help you filter air. So if our bronchioles are constricting, we're going to have bronchoconstriction, which is basically that thing in asthma where people can't breathe because they're like, you know what I mean? So like it's going to cause asthma. It's going to lead to asthma, and it's going to lead to vasodilation, which is going to lead to hypotension. That's why people with allergic reactions, it's inflammation that's kind of their, well, not inflammation, it's histamine that is their, that's their kryptonite, okay? That's what's causing them to have this bronchoconstriction. And also, when a mast cell degranulates, it doesn't just produce histamine, it does a bunch of other things too, although histamine is like the number one most important thing you should know. It also produces something called an eosinophil chemotactic factor, so that is an ECF. This is like the only time I'm going to mention this though, so you don't need to, it's an ECF. I don't know what I'm saying, bro. So what does an eosinophil chemotactic factor do? Well, simple. It's going to have eosinophils moving towards a chemical stimulus. Okay, so it's in the name, eosinophil chemotactic factors. It's going to call eosinophils to wherever it is. These eosinophils are going to degranulate to release histaminase. Okay, histaminase is going to stop the production of histamine. There's supposed to be an E here. It's pretty cool, right? Because the mast cells are not only producing histamine, they're also producing another pathway that's going to stop histamine from being produced. So in most people, I want to assume, people without asthma, this pathway is probably like fully functional, right? But in people with asthma, there's probably something going wrong here that's causing the histamine to not be stopped as soon as it should be. And that's going to cause them to have this like bronchoconstriction and vasodilation and all that because this pathway is not properly up and running. But then the thing with the body is that there are so many different things that can have the exact same effect. Okay, so maybe one person with asthma has asthma because this pathway is not working, and then another person with asthma can have asthma because of a completely different pathway. You know what I mean? So it's like there's multiple different ways that one thing can happen. But that's just me like going off on a tangent. And then what activates a mast cell? Well, one of the things is interleukin-1. Interleukin-1 is another type of chemical that's being released here, right? So for the inflammatory chemicals, we already have cytokines and IL-1, okay? So, and then we have bacteria and viruses. So the pathogen itself can activate a mast cell. Then we have antibodies and we have complements. And the complements are the things that we talked about here, right? And that's that chemotactic factor thing. Look, it came back again. Would you look at that? So, okay, yeah, let's cap that there. So that's that. And then we have, so all these things that I just said, these are the immediate response to a mast cell being activated. Okay, but there's also something else that happens when a mast cell is activated, and this is called the delayed response. And I'm only going to focus on two things. There's more than two things, but like I said, we only need to focus on these two because these are the most important ones. So first, we're going to have leukotrienes, which are kind of like histamine 2.0. Although calling them histamine 2.0 isn't really right, because if I say something is 2.0, then it's supposed to be like the better version of it. But leukotriene is not the better version of histamine. Okay, it's literally just histamine's twin. Okay, so I guess 2.0 is wrong. It would be more like histamine number 2, because it's literally its twin. Like it does the exact same thing that histamine does. The only difference is that it takes about 6 to 8 hours for leukotrienes to be made. Okay, so remember how histamine can lead to anaphylaxis, okay, or asthma? And oh my God. So I said asthma, but it's basically anaphylaxis, which is asthma. So leukotrienes can lead to anaphylaxis. But the thing is, they don't happen immediately. They happen almost 6 to 8 hours later, which is why when someone has an anaphylactic shock and you give them an EpiPen, which is epinephrine, you're not supposed to just, send them home. You're supposed to take them to a hospital, because if you leave them to their own devices, 6 to 8 hours later, leukotriene can be, hiding in the dark, waiting for his chance. And then once he gets that chance, he's going to cause another reaction by doing the exact same thing that histamine does, which is bronchoconstriction, okay? So that's what you gotta look out for. Another thing that mast cells will do is the production of prostaglandins. And prostaglandins are responsible for pain, inflammation, and vasodilation. See how inflammation keeps popping up? See how it keeps popping up? Like I said, you never really get rid of it. And how does it cause inflammation? Well, that's because prostaglandins will lead to increased cellular permeability. And remember, that's this thing, okay? So I do have this little note here because I kind of linked it to pharm, to what we're learning in pharm. But basically, NSAIDs work by inhibiting COX-1 and COX-2. And COX-2 is the thing that's responsible for producing prostaglandins, right? And prostaglandins are responsible for pain, inflammation, and vasodilation. So if NSAIDs inhibit COX-2, and COX-2 makes this, so NSAIDs inhibit the making of this thing, which is why NSAIDs are painkillers, or they can be used as a painkiller because they inhibit COX-2, which is the thing responsible for making prostaglandins. So that's just, I love connecting the dots between the classes. It just makes it feel more satisfying when I'm learning. But yeah, so you probably remember what I said about when you think of pain, you should think of bradykinins, right? Here. Well, yeah, that is true. Okay, bradykinins are like the number one cause for pain, but prostaglandins come in at a very close second. Where is it? Yeah, they come in at a very close second. So when you think of pain, think of prostaglandins and bradykinins. Okay, but like I said, we have to build on stuff, And so that's basically that. So now we're going to talk about the histamine receptors. How does that work? Well, there's two main histamine receptors. There's H1 and H2. H1 is the one you really have to worry about. Okay, because this is what causes the smooth muscle contractions, and it also, H1 is the main player. It's the main player because it causes the smooth muscle contractions, it causes the chemotaxis, and it causes the prostaglandin synthesis. So a lot of the things that we know about histamine is being caused by H1. H2 is kind of like the more unknown one, or not really unknown, but it's like the less popular one because it causes your stomach acids to secrete. It causes your stomach to secrete gastric acid, and it also causes anti-inflammatory properties. So it kind of does the opposite of the H1, and then reduces chemotaxis. Okay, so H1 will cause smooth muscle contraction, chemotaxis, and prostaglandins. H2 will reduce chemotaxis. Okay, it's anti-inflammatory, and it causes the stomach to secrete gastric acid. And yeah, that's what you need to know. Okay, so now let's talk about wound healing. Okay, so say we already know what's going on. We partially know what's going on in the body when you get an infection or when you stub your toe because of like you hit yourself or like when you get a cut. Now we kind of understand, but let's talk about wound healing. So there's 4 main stages of wound healing. There's hemostasis, inflammation. See, inflammation, it's there again. There's proliferation, there's remodeling, okay? And sometimes, depending on what textbook you use, hemostasis and inflammation will be the same thing. Like they'll both be classified under one step. So in some places you have 3 stages of wound healing, but in some places you have 4. But that's just because some people break these down into 2 different steps. Other people like to group them as one. That doesn't really change anything because patho's not going to care about the name. They're just going to want to know if you know it, right? They don't care if it's, oh, well, there's actually, like, they're not going to nitpick that much. Okay, so let's talk about hemostasis. And I like to separate them into these sentences. So the stages of wound healing is step 1, stop the bleeding. If there's bleeding, okay, stop the bleeding. Step 2, clean the wound. Right? Step 3, rebuild the wound. And step 4 is strengthen it. And it kind of makes sense when you think about it as that instead of just memorizing hemostasis, inflammation, proliferation, and remodeling. Like when you think of it as actual things, for me at least, it's easier to memorize. So hemostasis is stop the bleeding. So think of all the things that happen to stop bleeding. Well, we're going to have our blood vessels constricting. We're going to have blood. It's going to start coagulating. Next, we're going to have an increase in the number of platelets that's at the site of the wound. And these platelets are going to come together to form a thrombus, which is a blood clot. And that blood clot will stop the bleeding temporarily. Okay, and that is to set the stage for inflammation. So there's going to be So once the vessels constrict to stop the bleeding, right, we're going to have vasodilation. So once the blood clot has been put in place, so that hole that was made in the blood vessel or in the cell or in the tissue has been temporarily closed, the blood vessels are going to dilate again, and that is to do defense, cleanup, right? Because when your blood when you get a cut, all this bacteria is introduced into your body, right? All the bacteria on the outside. It can be the bacteria that lives on your skin, the bacteria from your clothes, the bacteria from dust, sand, dirt, whatever it is, it's going to get inside the body. And that's going to trigger this pathway. See how I said everything keeps leading back to everything? And it always boils down to inflammation. So it's going to trigger that pathway. And we're going to have 2 reasons for vasodilation. One is defense, and 2 is cleanup. So neutrophils are primarily responsible for the defense. Because most times the bacteria that enters will be, your run-of-the-mill, easy peasy, lemon squeezy to defeat bacteria. That's why we don't die when you get a blood clot, when you get a cut on your finger, like a paper cut or something, because it's like, most of the time you're not going to go to the hospital for a paper cut. Okay, that's because most of the bacteria that you do get are easy to clean up by the neutrophils. Then we have the macrophages. Macrophages also clean up the bacteria, but they do something else. They release something known as a growth factor, which will stimulate the growth of new cells. Okay, it'll stimulate, production. It's going to set the stage for proliferation, which is building the wounds, rebuilding the wound. First, we're going to have angiogenesis, and angiogenesis is known as the development of new blood vessels. Okay, so that's angiogenesis. Then we're going to have fibroblast synthesis, and fibroblasts are going to come in and make something known as collagen. And this is the thing that we find in our skin. That's why a bunch of influencers take collagen supplements. Old people take collagen supplements because it helps with our skin. So When you get a cut, fibroblast is going to come in and synthesize collagen. And also, the older you get, the less collagen you make, which is why old people, like people in their 30s, 40s, 50s, like they take collagen supplements to kind of help the fact that their body is not producing enough collagen anymore. That's just a side note. Like I said, these little things, that's what helps me remember stuff. But for some people, it's like, why are you telling me this useless information? And honestly, real. So the next thing we're going to have is the formulation of granulation tissue. If you're wondering what granulation tissue is, it's just like, you know when you get a wound and it has like, in the first day of the wound healing, it has like a scab and you can peel it off and it's kind of red and bumpy. That's granulation tissue. Next, we're going to have something known as epithelialization, which is basically when the epithelial cells, right, they move to cover where the wound is, right? And they start building from there. So if this, let me draw it out so you can kind of understand. So this is the wound, right? So this is the wound. So first we have the blood clot from the thrombus, which is in step 1, and that was temporary. Then we brought in our neurophages and macrophages, and they cleaned everything up and they stimulated the growth. Next we have granulation tissue, which is the scab. And most people peel off scabs. You're not supposed to do that, but most people do. I'm not gonna expose myself, but some people do, not me though. So once the scab is peeled off, all our epithelial cells that were on the side, they're gonna move here, right? They're gonna move here to kind of bridge that gap, okay? And the next thing we do is we remodel, because this thing is not strong enough to withstand the things that we do on a normal basis, like washing our hands, cooking, cleaning. Like this is too weak. So that's when we get this stage. And collagen in this stage is replaced with a much stronger item, and you'll never believe what it's called. Type 1 collagen. Isn't that incredible? And then we have the formation of scar tissue. And another thing that I thought was really interesting, but you don't really have to know it, but it's also very interesting, is that when you have scar tissue, there's fewer melanocytes in it than with the original tissue. And melanocytes are what is responsible for our skin color, which is why a lot of times scars look, they have a different color from the actual, from the skin around it, because we have like either fewer melanocytes or more melanocytes, but that's basically what that is. And this stage of wound healing can take weeks, months to years. And some wounds never even fully heal, right? They're always stuck in like in between these two phases. Like some wounds never really heal, okay? Some do, some don't. That's just the way the cookie crumbles. And there is functional versus non-functional wounds. Okay, and a functional wound basically means that it's, you know, it's good and back to normal. Oh, also back to this, just like a side note, is that's why when a celebrity, like a basketball player, yeah, that's what it's called, a basketball player or a football player or even a hockey player, just anything, when they get like an ACL tear, or, you know, if a tennis player like sprains his wrist, that's why most times they can never really get back to the peak that they were at, because their tissues that are at their ankle or their wrist or their Achilles, like wherever that tissue was that was scarred, is replaced with scar tissue. And scar tissue is always going to be weaker than what was originally there. So that Achilles tendon is never going to be the way it was before, because instead of it being replaced with tissues for your tendon, it's going to be replaced with scar tissue. And scar tissue is not going to move the way that Achilles tendons would move. Okay, that's why if you're an athlete, it's really advised that you don't get a serious injury, that you don't strain your body, or you don't do anything that's going to injure you. Because when you get injured, for you to achieve the level of peak that your body once had, it's going to be very hard. And for most people, it's impossible. Okay, that's why a bunch of celebrities and people, like when they get an injury, they retire, or, you know, they start losing matches, they're not as strong as they were before. That's because of that. Okay, so back to this functional and non-functional wound. So a functional wound is a wound that basically regains its property. So like if I cut my finger, and it heals, right? So regains its property basically means that I can sense things. I can do what I was doing before. Okay, so if you injure your knee and you're still able to like move your knee, and the skin on your knee is still, you know, like when you raise your knee, like the skin will mold together. And when you put your knee down, it'll like extend. If you get an injury on your knee and your knee can still do that, that means that it's regained its property. That means it's functional. If you get an injury on your knee and it cannot do that, well then it's non-functional. Okay, another example is you can sense things. Like if you have an injury on your finger, right, and you put your finger towards like a heat source, it could be a candle or a light. If you can sense the heat on it, then it's good, right? If you have a healed wound on your hand, and I touch it with like a pen, and you can feel the pressure, then it's good because it's functional. That means it has all the blood vessels and all the nerves and stuff. If you can't, that means it's non-functional. And there's another type of a wound called a keloid scar, which is basically when there's too much collagen being deposited, so the scar is kind of like raised up. It's higher than the rest of the skin around it because there's way too much collagen. Sometimes they're harmless, sometimes they're not. That's all you need to know about that. Now we're gonna move on to adaptive immunity, and we're like literally almost done, guys. Literally, like this is the last page, and this is where we are. Okay, so remember, these are our big guns. Okay, these are the cool kids, but they didn't always start off like this. Okay, they actually were like little baby cells. They were like little normal tiny baby cells. Okay, and they were actually developed in the bone marrow. So this is where they are, and right now they are normal cells. Okay, they're normal cells. And once they develop in the bone marrow, this is where they're born. And, you know, cells can't be born, they're made here, but, you know, we like to humanize things over here, so this is where they're born. And then once they're born, they have to go to boarding school. And boarding school is the primary lymphoid organ. And fun fact, the cell is named after where it went to boarding school. Okay, so kind of think about how, you know, people in high school have jackets from, you know, wherever high school they went to, like, oh, I went to Pato, so I have a Pato jacket, or I went to like LSU, so I have an LSU jacket. That's kind of how this works, right? So so your T lymphocytes, they go to the thymus, and that's why they're called T lymphocytes, because T for thymus. Okay, and the thymus is a lymphoid organ. It's around your neck, I think. And then your B lymphocytes, they stay in the bone marrow, so they're called B lymphocytes for bone marrow. Okay, so when in the thymus, they get turned into T and B lymphocytes. This is where they gain all their mojo, right? This is where they gain the aura that comes with being a B or T lymphocyte in the thymus or in the bone marrow. So remember, T cells for thymus, B cells for bone marrow, okay? And in the thymus, they become what they are: a naive immunocompetent T cell in the thymus and a naive immunocompetent B cell in the bone marrow. So the B cell stays where it is. The T cell, like the B cell stays in his hometown. The T cell goes out to explore. That's another way you can look at it, because the B cell isn't leaving the bone marrow, like he's staying there. So once they become these things, like once they become what they are, at this point they're still young. Okay, they've never killed a pathogen before. They're just kind of chilling. They're just there. Okay, they're naive. That's why they're called naive, because they haven't killed anyone yet. Okay, so the thing is that the T cells, like I said, this is why I say the B cell is the chill one, and the T cells are kind of more aggressive, because the B cells, they like, they stay in the hometown, and they're just B cells. T cells, however, will differentiate into 3 different types of T cells. We have a T regulatory cell, a cytotoxic T cell, and a T helper cell. And if you remember, where is it? Oh my God. Okay, this is the T helper cell. Okay, this T lymphocyte, this is the cytotoxic T cell. So I just called it a T lymphocyte. So see how I said I was going to build on stuff and now I'm building? LOL. So this is the T cytotoxic T cell and this is the T helper cell. So I didn't, I'm not going to talk about the regulatory T cell because we don't really need to know everything about this process. Like it's literally just one slide in the exam slides, but you do need to know that they exist, right? So the naive immunocompetent T cell will divide into these 3 categories. So it's one of these 3. And the B cell, well, he's just a B cell. He doesn't do much. And then once they're done with high school, which is what I'm assuming this is the primary lymphoid organ, they get sent off to a secondary lymphoid organ. So think of this as college, okay? College for them. So for the T cells, they go to the spleen. I don't know if that's what a spleen looks like, but I figured I might as well go crazy with the drawings. Okay, they go to the spleen. And the B cells, they go to the lymph nodes. Okay? And that's pretty much what you need to know. And they just stay there until an infection happens. And then we're going to see the real process. Okay, so for now, just think about it. Like they stay here. The B cells stay in the lymph nodes, the T cells stay in the spleen. So let's go back to another thing. Remember how I said, where is it? That once the macrophages show up in the, once the macrophages arrive on scene, they're going to also start fighting. They're going to turn into a, once the monocytes arrive on screen, right? Remember they're Bruce Banner. They're going to turn into the Hulk, which is a macrophage. Okay, and the macrophages are going to try and kill the bacteria too. But if they're not successful, then we're going to unlock adaptive immunity. Remember when I said that? Well, now we're going to understand. Now we're going to delve deep into that. So the thing is, okay, we're going to understand how they work. So this is the macrophage. This is our Hulk. This is a dendrite. I brought this up before, and then this is our T helper cell, our little guy over here. So macrophages and dendrites are something we call antigen-presenting cells. Now I'm going to explain what that means, but I'm going to break it down. So first off, what's an antigen? An antigen is anything the immune system recognizes as foreign, something that is not normal. Okay, that is an antigen. An antigen is something that is not normal. So it could be, bacteria, it could be a virus, it could be toxins, it could be tumors from when we have cancers. Cancers are not normal, okay? So anything that the body recognizes, like, hey, that's not supposed to be there, is an antigen. And so by this definition, an antigen-presenting cell, these are cells that basically take these antigens and they show them to to other cells like, hey, this is an antigen. Okay, this is something that is not supposed to be in the body. But what cell is it showing it to? It's showing it to the T helper cell. Okay, but here's why I say the T helper cell is kind of like a little brother to these guys, because the T helper cell does not kill anybody. Okay, he's just a little sweetie patootie. Like, you're gonna tell him something and he's gonna run to his older brothers and tell them so they can deal with it. He himself is not gonna be doing any of that, like killing people stuff. That's their job. Okay, that's why I think of him as a sweetie patootie. Like, he's just a helper. Okay, that's why he's a T helper cell. He just helps people. He's just a chill guy. Okay, and so these antigen presenting cells, they're gonna take an antigen, which is a bacteria or a virus. They're gonna take a piece of the bacteria and show it to the T helper cell. And the T helper cell is gonna be like, whoa, oh my God, is that a bacteria? My brothers are gonna come kill it. And then he's gonna take the antigen to the T lymphocytes and the B lymphocytes. And mind you, they're still naive at this point in time. Okay, they're naive. So what he's going to do is he's going to find the T lymphocyte and the B lymphocytes that are made to kill that specific antigen. Okay, because when our body produces these cells, they produce millions of them for millions of antigens that we might never encounter in our whole lives. Okay, so he's going to go find the specific one of those millions of lymphocytes that are made specifically to kill that specific antigen, and he's going to show them and be like, yo, look what I found. There's there's a bacteria, there's a worm, there's a fungi, there's a virus in the blood, in the body that is not supposed to be there. So you guys, as my older brothers, have to go and kill it. Okay, and when he shows the antigen to them, they're going to be like, oh, word, and they're going to be activated, and they're going to go kill the cell. They're going to go kill the pathogen, which could be the bacteria, virus, toxin, tumor, or, they're going to go kill it. That's how this process works, okay? So let me give you a quick rundown. So this is the bacteria, all right? These guys are going to try to fight the bacteria. When they notice that fighting the bacteria is not going to work, one of them is going to take a piece of, because like usually there's going to be multiple bacterias. There's going to be many of them. They're just going to be everywhere. Okay, so when they notice that, hey, you and I and the neutrophils are not enough to deal with this threat, they're going to take a piece of one of the bacteria that they've already killed, right? Because there's many of them, but there's multiple. So they're going to take a piece of this guy's, and they're going to take this piece to the T helper cell. That's this guy over here. They're going to take it to him. Now, the thing is, he might be a T helper cell, and he might be all young and bubbly, but he's not stupid. Okay, like they can't just give him this antigen and be like, hey, take this antigen and go kill it. Like they can't just hand it to him. They need to present it in a certain way. I like to think of it as this antigen is like a piece of the bacteria, but he's like very picky, so they have to use a special type of plate. They have to use a special type of plate to put the bacteria on the plate and then give it to him. Like if it's not on this plate, he's not going to accept it. Okay, and what is this plate? This plate is something called a major histocompatibility complex, also known as an MHC. Okay, this thing. And there's 2 of them. There's MHC1 and MHC2. But antigen-presenting cells use MHC2. Okay, they are the only cells in the body that will use MHC2. And that is how this guy knows that they are legit, because they have this MHC2 plate. Okay, for the sake of my analogy, they have this plate. Okay, so if another cell brings an antigen and it does not have this plate, then that means that cell is not an antigen-presenting cell. So this guy is not going to pay them any attention. He's not going to care. Okay, but in this case, these are antigen-presenting cells. Both the dendrites and the macrophage are antigen-presenting cells. And remember, there's more than one antigen presenting cell. It's not just these two. There's many different types of them. And sometimes B cells could also be antigen presenting, okay? Because remember how I said there's multiple different things that can activate these cells. Like it's not just this guy, but let's finish the pathway. So this guy puts the antigen on a plate and he takes it to the T helper cell. And the T helper cell is like, whoa, is that an antigen? And this guy's like, yes, go tell your brothers to deal with it. And he's like, bet. So he takes the antigen and he takes it to them and he finds the specific T lymph. He doesn't just take it to any of his brothers. He takes it to the brothers that will be able to deal with this, right? To one of the millions of them that was made specifically to deal with this. Oop, no, it's not what I meant to do. With this specific type of antigen. So when he finds those, he's going to tell them, like, he's going to activate them. He's going to activate the B cells and he's going to activate the red cells. And he's also going to activate them to produce something called a memory cell. And this is where the specific, this is where the memory part of the adaptive immunity comes into play, right? Because when he finds out that these guys, because when the T helper cell finds out that these guys have the ability to kill this pathogen, he's going to be like, okay, I'm going to give you guys the permission to create a memory cell. So they're basically going to duplicate themselves. And these duplicates are going to go and stay in a special part of our body, and they're going to remain there until this same pathogen shows up again. Only the next time it shows up, he's not going to have to bother with activating them because these cells are already going to be here. The memory cells are already going to be here. So he's just going to go straight to the memory cells, okay? And that's why adaptive immunity has memory, because of this pathway, because of the duplication and the saving of these memory cells. With innate immunity, all these things that I've just explained, inflammation, fever, swelling, redness, heat, like they don't remember stuff. It doesn't matter who you are, they will always do this. But with adaptive immunity, once they realize that, hey, this antigen has been here before, we're going to go straight to this. We're not going to take any pathways. We're going to go straight to the memory cells, okay? So let's continue. So he takes it to them and he says, guys, look at what I found. Duplicate and save your memory and go kill this dude. And so they're going to be like, I bet. And so they're going to duplicate themselves and save the memory cells. And the memory cells are going to be kept away for later, for when next we need it. So once they duplicate, once they save the memory cells, they're going to go off and kill the antigen, the bacteria or virus or something. They're going to go kill whatever this thing came from, okay? Now here's another reason why I say blue is chill, like the B lymphocyte is chill and this T lymphocyte is not chill. Because B lymphocytes, they don't actually move, like they don't go anywhere. What they do is they release something called an antibody. So I like to think B lymphocytes stay in the bone marrow and they produce antibodies, okay? And they're chill, right? So these antibodies are what's going to go, and it's known as something called humoral immunity. But yeah, so they produce antibodies. They don't actually, carry knives, okay? That's what this guy does. So the T cell, he is going to actually go into the body. So like, think about it this way. B cells, they throw grenades, okay? And the grenades are these antibodies. That's not how you... These are their grenades. T cells, however, they carry knives. So they go up to the virus and they like stab it and they kill it. B cells, however, they throw out the antibodies and they stay where they are. So that's why he's chill. He stays in one place and he sends out his grenades. This guy will actually go up to the intruder and kill him. That's why I say, and I like to think about it because the B cell is chill because he stays in the bone marrow at first. You remember what I said? Like he stays in the hometown. But the T cell, he's gone out and he's seen the world. So he's harsher. But this is just me. Like I said, I love humanizing them because it makes it easier for me to remember what they do. Thinking about it like a movie instead of, what's happening in my body. So this is the T cell. And this undergoes something called humoral. And humor is basically like in, I think it's ancient Latin or Greece or something, but humor basically meant fluids. So this B cell is going to release these antibodies into the fluid, right? Which is, it could be blood, it could be plasma, it could be your interstitial fluid, but it's going to release these antibodies and they're going to go into the fluid and do what they need to do. T cells, however, now let's go over why they're called cytotoxic. Well, cyto means cell and toxic means toxic. So they're toxic to cells. Okay, let's rewind a little bit. So remember how I said and only antigen presenting cells have MHC2 proteins? Well, what about MHC1? All right. So MHC1 proteins are found on all cells. So every cell in your body has MHC1 protein, okay? And these MHC1 proteins can activate cytotoxic T cells directly. So this is one, so the helper T cell is one way that a cytotoxic T cell can be activated, but another way is through the MHC1 protein on a normal cell. And it makes sense, right? Because think about a virus. So the way viruses infect the cell is that they go into the cell and they take over the cell. So they're like zombies. Viruses are like zombies. Like they go into the cell and they take control of the cell and they use the cell to do what they need to do, which is to replicate. So usually when a cell is in function, it will present a piece of itself on its MHC1 molecules. And when the cytotoxic T cell is passing by, he sees that the cell's MHC1 molecules are normal and he ignores it and he just keeps it pushing, right? But in the case of a viral infection, right? So say there's a virus in here and the virus has taken over the cell is now going to be presenting antigens with the virus in it. Okay, so when the cytotoxic T cell sees that, hey, yo, wait a minute, this is a virus, this isn't the cell, then he's going to be activated and he's going to create a memory cell and then he's going to kill it. That's how that works. Okay, that's why it's important for for cytotoxic T cells to also be activated by the MHC1 molecules that are on all the cells. Okay, another thing that is beneficial by this is because cancer. Okay, and some people think that cancer only happens to people who get really sick, but that's not true because we have cancerous cells in our bodies all the time. Well, not all the time, but sometimes. But the thing is, if there's a cell that's cancerous, okay, so let's say this wasn't a virus, let's say this was a cell that was cancerous, right? Whatever it's producing up here is going to be cancerous. So the cytotoxic T cell is also going to see this cancer cell and be like, whoa, you're not a normal cell, you're cancer. And he's going to kill it. Too, he's also going to kill it. Like I said, he doesn't play. If it's not normal, even if it's not like a bad normal, it could be an average not normal. But as long as it is not normal, he's not playing. The cell is gone. He's killing it. Okay, and it's good, right? Because cancer, you don't want to have cancer. So sometimes people with cancer, you can see that there's a problem with this pathway. And that's why like the cancer is left unchecked. That's why some people with HIV can also get cancer, because HIV kills this guy. And if this guy's dead, then this guy, well, HIV weakens your immune system, because even though MHC1 molecules can personally present to cytotoxic T cells, helper T cells are the main presenter. That's why he's still very important, okay, because he's the main presenter. All right, and HIV is going to kill this guy. And if this guy's killed, then this guy, most of the time, he's not going to be activated. And if he's not activated, then if you have a cancerous cell, he's not going to be, up and about enough to do something about it. That's why if you have HIV, you can develop cancer. You can get a bunch of sicknesses because your immune system in general, because cancer isn't the only thing he kills. He also kills viruses and he kills bacteria. So that's why when you get HIV, you're supposed to get it treated like stat, so it doesn't develop and it doesn't kill off all of them, so that you can prevent yourself from getting all sorts of other sicknesses. Oh no, he lost his sheen. Okay, yeah, there we go. So that's basically that. So now, like I already kind of talked about this, but I'll just go over it again. So like I said, these guys are more aggressive and they are cell-mediated, okay? That's why they're called cytotoxic, because they kill cells. And they're mostly used in viral infections. All right, they kill the cells themselves. And these guys are chill and they're humoral, and they produce antibodies which float around in fluid. Okay, and these antibodies are also called immunoglobulins. That's just another name for them. And there's 5 main types. So we have IgA, which is immunoglobulin A, immunoglobulin E, immunoglobulin G, immunoglobulin D, and immunoglobulin M. So I have highlighted here a few things that each of them does. So immunoglobulin G is the most abundant. Okay, so it's like 70% of your antibodies. All right, it's the most abundant one. Immunoglobulin M isn't as abundant as immunoglobulin G, but in an initial infection, it is the first one to be produced. Okay, so if you have a patient come in, okay, so you're not going to do this. I think this is going to be the lab results or something. But if you have a patient come in and they order lab results, right, and they see in the lab results that there's more IgMs than there are IgGs, that is a sign that this is the first time this person is experiencing these infections, because IgMs will be produced first, then IgGs are produced. Okay. Next, we have IgE, which is responsible for your allergic reactions. Why is this responsible for your allergic reactions? Well, let's go back to mast cells, okay? You see, IgE will activate a mast cell, and mast cells will activate histamine, and histamine activates vasodilation, and vasodilation can cause anaphylaxis, which can lead to asthma. But you see, asthma is not the only thing that can cause anaphylaxis. People who are allergic to peanuts, or people who are allergic to hay fever. So when you get into contact with peanuts or hay fever or milk or whatever you're allergic to, you're going to stimulate your IgE. And your IgE is going to go ahead and tell the mast cell to release histamine. And the histamine is going to go and do all this, which is why you're supposed to have epinephrine. So I like to think of like IgE, epinephrine, allergic. Okay, so IgE will stimulate an allergic reaction. How do you combat an allergic reaction? With epinephrine. Okay, then we have IgA, which is secretions. All right, so this is saliva, tears, breast milk. This is also why your saliva in the beginning, see how I said everything is always going to lead back to everything? This is also how your saliva is a chemical barrier, because it contains IgA. They contain IgA antibodies. They also contain other enzymes that do other things too, but like I'm just trying to link stuff, just trying to find a little connection in these things. Okay, and then another thing is that because IgA is in secretion, it is transferred. Okay, wait. I'm going to do IgA last because it's going to tie into the next topic. So I'll do IgD. And IgD is found on B cell surfaces. Honestly, the thing is, when I studied this in microbiology, people didn't even know what IgD does. Like, it was just there. But now I guess we know. But you still don't need to know it for patho. So just remember, the only thing you need to know is that if you get a test back and you have IgM more than IgG, then that means this is the person's first time experiencing that infection. If you have IgG more than you have IgM, that means that this is not the first time the person has experienced this infection, okay? And then remember that IgE is allergic reactions, okay? That's what leads to that's another thing that can cause mast cells to degranulate, which can lead to anaphylaxis, okay? And then we have, you don't even need to know about IgD, just know that it exists, okay? Just know that it exists, and you can find it on the B cell surface. And then IgA is found in secretions, okay? So that's tears, saliva, what else? Breast milk, okay? And this is why it's a lot of people say that it's really good if you can breastfeed your child, or if you can give your child breastfeed milk. Okay, because breastfeeding, the milk from your boobs contains IgA. And IgA are a type of antibodies, right? And when a baby is born, they don't have any antibodies of their own. Because remember, with adaptive immunity, you have to earn it. Okay, you're not born, where is it? Yeah, you're not, you have to, with adaptive immunity, you have to earn it. You're not born with it. Okay, you're born with your innate immunity. As a baby, you're born with your skin, you're born with saliva, you're born with tears, you're born with stomach acid, and you're born with bacteria on you because of, the bacteria from your mom's stomach or whatever. But you're not born with your antibodies, right? So when you're born and you drink your mom's breast milk, the IgA antibodies from that breast milk are going to be transferred into your system. And so for the first few months of your life, you're going to be surviving based on the antibodies from your mom. That is until you start getting exposed to things like, as a baby, you get exposed to dust or you get exposed to other things, and that will stimulate your immune system to create its own antibodies. But for those first few months, you're solely reliant on your mom's, and that's that IgA. Okay? So now let's talk about active versus passive immunity. And this kind of ties into what I said, but I'm going to show you how. So active immunity basically means that you earned it. Okay, so you had an infection, or your body encountered a pathogen, and it went through this whole process. Okay, that is active immunity. Passive immunity means that somebody gave you the antibodies. Somebody gave you the cytotoxic T cell. Like the T cell wasn't activated, there was no memory cell stored, nothing like that. Okay, someone gave it to you, right? And so in a case of active immunity, this was like natural exposure. And immunization kind of works this way. At least most immunizations do. So what they'll do is that they'll introduce you to like a weak version of the virus or the pathogen. And then because your body has that weaker version, they're going to stimulate the T cells and the B cells that can kill this weak version of the pathogen, right? And once they get stimulated, they're going to store some memories. So when you actually do meet the strong, why is it turned upside down? So when you do meet the strong version of the pathogen, your body already knows how to kill them. You already know which lymphocytes can kill it. Okay, and that's why active immunity is preferred. It is preferred in most cases, okay? And that's why, Okay, and then we have natural exposure. I feel like I already explained that. And then for passive immunity, it's when someone else gives you the antibodies. So what's a good example of this? Pregnancy, like I just said. When your mom transfers IgA antibodies to you during breastfeeding. That's a good example of passive immunity because you're getting the antibodies straight. Okay, you're not getting the B cells, you're not getting the memory, you're getting the antibodies straight. Or you're getting the lymphocytes straight. And another example is when you get bit by a snake. I don't know if you know this, but usually if you're in the wild, right, and you get bit by a snake, you're supposed to take the snake that bit you to the doctor so that they can extract the poison from the snake venom and create antibodies that will prevent the snake poison from killing you. Okay, so yeah, so that's that. And the thing with passive immunity is that it's temporary. Why? Because you're getting the antibodies. You're not getting the memory cells. So your body's not going to remember what to do once these cells die because all cells have a shelf life. Like they're all going to disintegrate one day. Some shelf lives are longer than others, right? Like memory cells will last you till the end of life. Red blood cells are only going to last you about 180 days. You know what I mean? So like all cells have a shelf life, but your antibodies are only going to last you for as long as they can. Once they die, like once the antibodies or the T lymphocytes that you received passively dies, the memory of them dies with them because your body didn't activate the lymphocytes. You just got them. So they don't have memory cells, which is why for a lot of children, they encourage them to go outside and to play in the dirt and to roll around in mud because when you're doing that, you're having a natural exposure to pathogens. And this natural exposure is storing your memory cells so that you can become, so that you're stronger, your immunity is stronger. Right? That's why they tell you like, oh, go have fun with other children to build your immunity. Another thing is like when kids are young, well I heard about this from a friend. I got the chickenpox vaccine, so I don't know. But a good example is that when back in the good old days, right, it was common practice for you to get children and put your children and then put them with children who had chickenpox so that your children would get chickenpox and then build a natural immunity to it, especially if it was a weaker version of the chickenpox. So then once they have this natural immunity to it, right, they're going to get the memory cells because it's active, right? They're going to actually get chickenpox and then their body's going to have to fight off the chickenpox. So they're going to build the memory cells so that when they do see a stronger version of the chickenpox, your body's going to be able to fight it off. And that's literally immunization before immunization, was created. But yeah, and that marks the end of Unit 2.